Our topic today is 2015 is here. Is ICD 10? Today's presenters are Dr. Betty Bibbins, MD, founder, CEO, executive physician educator for DocuComp LLC, and George B. Breen, Esquire, Board of Directors, member Epstein, Becker, and Green, PC. Today's presentation will review the impact of the timeline needed to prepare physician communications to justify the utilization of resources in today's changing regulatory healthcare environment. Recognize the similarities for appropriate documentation within the medical record for ICD-9 and when ICD-10 is implemented. Will we see ICD-10 in 2015? If so, what are the viewpoints? And how does the playing field measure up? ICD-10 brings more enforcement risk to providers. We will review the areas providers ought to be concerned about. Dr. Bibbins is founder, CEO, and executive physician educator of DocuComp LLC that provides physician documentation education, compliance, and continuing education. She has more than 35 years of healthcare experience in the areas of nursing, clinical medicine, and administration, as well as a strong record in education and management. She is a national leader in clinical documentation education for hospitalists and attending physicians. Dr. Bibbins has also authored numerous articles in publications and the book, Documentation Tips for Inpatient Care. I present to you now Dr. Betty Bibbins.
Good afternoon, everyone. Thanks, Debbie. Okay, here we are. We're bright and early into 2015. And what we'd like to start with is the quotes that got us to where we are today, beginning back on February 27th, 2014, when Marilyn Tabner, Administrator for Centers of Medicare and Medicaid Services, made the national announcement to the Health Information and Management Systems Society National Conference that there will be no more delays and the system for ICD-10 will go into effect on October 1st, 2014. Let's face it, guys, we've delayed this several times and it's time to move on. But that was before House Resolution passed in Congress, House Resolution 4302. Surprise. The preparation, education, and software acquisitions, conversions, modifications by healthcare providers that have been in a frenzy to be in compliance by October 1st, 2014 came to a screeching halt on April 1st, 2014. Resolution 4302, Protecting Access to Medicare Act of 2014, this resolution was introduced on March 26, in 2014 in the House. It was passed on March 27, 2014 in the U.S. House. It was received by the Senate on March 27, 2014, passed by the Senate on the evening of March 31, 2014, and enacted to law on April 1st, 2014. This became Public Law 113-93, which states that from transition from ICD-9 to ICD-10 would not begin, may not begin prior to October 1st, 2015. Now, one thing we have to keep in mind are the words prior to October 1st, 2015. It doesn't mean that it definitely will begin. It's just that it cannot be implemented prior to that time, but there is the possibility that it potentially could be implemented after that date. But since we are still receiving feedback from CMS that we have to, and the plans are to implement it October 1st, 2015, we are now in the beginning of another cycle in order to begin preparing for the complexity and the specificity that will be required in the documentation, coding, and communication of care being provided to patients. And these areas being provided go through the components of it makes no difference whether we are in ICD-9, what we are today, or whether we're moving into greater specificity of ICD-10. The components that need explicit documentation in order to have the words there so that coding can be done appropriately, that billing can be done based on the coding appropriately, and appropriate communication of quality of care and other components that we'll discuss in a second will be communicated to all third-party payers and to CMS when government insurances are included. These areas that need to be captured include severity of illness. Instead of just having the generalities of severity of illness of a patient has a disease process, ICD-10, as majority of us know, in attending today's webinar, the specificity that is now is just the patient has a process or not. Whether it's mild, moderate, severe, extensive, is to a degree not compounded into the actual diagnosis or for reimbursement. It's whether the actual disease process is present or not. When we go to ICD-10, the specificity of mild, moderate, severe, extreme, these components will be important because the capture and the reimbursement and the medical necessity will all be combined to be what is required for that patient today and the severity of illness that is there today at the time of observation or admission or an encounter when they are seen in their offices. It's important to know exactly what is being medically managed. And that then justifies the intensity of services and the medical necessity that is needed for the care and the severity of illness, with medical necessity being the component to justify the resources and consumption justification. Why are we utilizing more extensive medications for a disease process if it's considered and documented as a mild severity of illness versus having a greater severity of illness, which would justify the medical necessity of resource consumption of a more expensive or more extensive regimen for care. And then all of this equates together to give us quality of care. And the quality of care is when there is an appropriate balance of severity of illness to intensity of care with medical necessity and consumption resources. And when we have this, then health care will be in a balance. And we will be shown to be providing appropriate quality of care for the patients we are providing care for. Timeline for physician ICD-10 education, familiarization, and implementation. There are many components that go along with learning a new language or having a greater degree of specificity within the language we're using now. And with that, we have to start with overall education. And we're saying, well, physicians have been getting education Yes, we have been getting physician education, and this has been going on to the point that we have a whole new area in healthcare. This whole new area is clinical documentation improvement. And with that, this is what is helping physicians to know what our specificity, what requirements are. We, in the practice of medicine, have a number one goal. Our number one goal is to provide good health care to our patients. Yes, we have to understand the rules and regulations, but we have to provide good health care to our patients, and that is our primary goal, and communication of that is still a major goal, but it's a secondary goal of communicating with the primary goal of actually providing the care. But we need to see that these are very important, because if communication of care is not done appropriately, then patients will not see us as providing good quality of care. Facilities will not be seen as providing good quality of care appropriate for the severity of illness. And third-party payers then will be taking second and third looks and having greater degrees of audits and denials for care provided until greater justification is shown. And therefore, with this education that has been going on for years, when we go to ICD-10, we have to not only show that education has occurred, but that the physicians, or all providers, are familiar and able to integrate the language into the actual communication of the practice of medicine. And with this familiarity and implementation, then we will have to do it in multiple modalities, including not only the paper record, where we use a pen and hand and use our hands to power of the pen to write, but communicate in the electronic health record in various formats and in various templates to utilize appropriate severity of illness and terms of medical necessity that truly translate into the care that was provided. And with this, then there will be full implementation of ICD-10, and this is not an overnight practice. And that is because the biggest thing we really have to keep in mind is that while we are still in ICD-10, ICD-9, there are billions of dollars still being recovered back by third-party payers, and we haven't even begun to practicing for ICD-10. We are still full-blown in ICD-9 that has been in effect for over 30 years. And in 2015, the OIG work plan, had expected that through 2014, there would be recoveries of over $4.9 billion, including over $800 million in audit receivables and about $4 billion in investigative receivables. This is just the various ways through key toms as well as through the auditing, the random and targeted auditing of diagnoses and facilities. In the past, they've been emphasizing hospitals, but they've made it also clear that beginning 2015, we're going to start looking closer and more strongly at outpatient cares at clinics and physician practices and ambulatory centers, because there has been an estimate by the OIG that up to 55% of E&M submissions may not be appropriately communicated, and that there may be varying degrees of inappropriate or incorrect billings coming from E&M. And so that will, again, be a target in 2015, beginning this year, as hospitals and other facilities have been in the past. These RACs have actually reported recoveries of tens of billions of dollars in the third quarter, through the third quarter of 2014. And we're tallying for the final numbers at that time. And of the $2.3 billion that RACs collected in overpayments in fiscal year 2013, more than $200 million went to the auditors as part of their contingency fees that range from anywhere from 9.5 to 12%. So there are the RACs, and with the addition of the MACs, as we know, they are receiving a compensation for amounts, a percentage of what they have returned back to Medicare. And again, this is in tens of billions of dollars. Other changes that are coming along that we will be addressing in other programs down the road, including the changing of the processes, including administrative law judges now not being an active part of the third level review. And there are multiple modalities being utilized now, with one of the greater ones being third-party payers that do their own third-level reviews, or taking 67% of what is due the hospital as a payment in lieu of challenging or appealing a denial, as well as the administrative law judges who are not accepting new appeals. And if they are, then you're informed as a facility or as a provider that it may be up to 18 months to 2 years before this will even be placed on the administrative law judge's calendar to be considered, to be reviewed. And so that's an awful long time to be waiting for reimbursements. And all of these are going on, and we have not even begun ICD-10 yet. And with the implementation of continuation of the RACs and MACs and audits and reviews, and the requirement that when we begin, there be the greater specificity from October 1st of whichever year. Hopefully, if it is needed, yes, it will begin 2015 and not be projected further into the future. I think that Mr. Breen is going to be discussing that component and that potential that is evolving in healthcare. And with that, it's important to understand the impact of explicit documentation. And this is where the level of severity of illness under our current MSDRG system is impacted by the presence or absence of complications and comorbid conditions. In areas such as Maryland, where the all-payer refined DRGs are, and some other states are looking in these areas also, you know, just look at the principal diagnosis and what comorbid complicating chronic conditions or major comorbid complicating or chronic conditions are there. They're looking at the total patient. And this may be in a more appropriate way to look at it, because disease processes do interact, and one can, like a domino effect, impact a worsening or impact other processes a patient may have. A patient may come in with dehydration, but if that patient has chronic systolic or diastolic congestive heart failure, one has to take into account that they can be hydrated at only such a level, because it could knock them from a chronic stable systolic or diastolic CHF into an acute phase, which would increase severity of illness, increase length of stay, increase consumption of resources, question the consumption of resources if it's not appropriately documented, and also question quality of care if there is a direct link as to quality or amount of hydration that caused the acute CHF state to occur. And so all of this has to be kept into account. With the majority of states right now and majority of areas, there being a need for just the principal diagnosis and just a secondary list that don't appear, may or may not appear based on the documentation, to impact each other. So we have to capture these conditions because they all impact the whole patient and also impact the communication of why varying degrees of care are provided. And it doesn't just look like as if we as providers are just providing services because we have nothing else to do. Effective documentation of these major and major CCs, as well as straight comorbid, chronic, and complicated conditions, play a vital role in hospital reimbursement. This is where it is so important to capture all severity of illness. If a patient comes in for orthopedic problem, we still need to make sure that their medical conditions, their cardiac conditions, their renal conditions, their pulmonary conditions are also not only just addressed in the orders, but addressed in the progress notes to acknowledge that the physician is aware that there is multiple medical problems there, and these diagnoses can be coded and it can be captured in the complete reimbursement of the care, as well as calculation of quality of care provided, which would equate to also including length of stay for all these multiple conditions, and also justify, again, consumption of resources. Improved documentation of the current system is the single most effective method to assure the financial health as well as the well-being of capture of quality of care health of providers, be they individual providers or facility providers. And the communication is the only way that third-party payers and reviewers outside of the physician-patient relationship will know what is occurring in that physician-patient relationship. And in addition to improving reimbursement, proper documentation of CCs and MCCs diagnoses impact other quality metrics such as mentioned, length of stay. If a patient comes in with one diagnosis, that length of stay for that diagnosis is appropriate. But if they have other conditions that are also present at time of admission or occur subsequent to this, this will significantly impact length of stay, whether it be for 1 day or longer. It will also impact readmission rates. If you have patients that have chronic disease conditions that constantly, essentially, seesaw back and forth, that when one gets out of control, the patient comes in for one, but then they go back in a second condition may become uncontrolled, then readmission rates can soar. And so capturing all of the appropriate interrelated diagnoses really impact readmission rates and the justification, because when there's no justification, then that significantly and negatively impacts the quality of care for the provider, whether the provider be a facility, an office, or an individual. Also, mortality rates, the more complicated and the more significant disease processes and more the number that there are there, they impact the risk-adjusted diagnoses and captures true complexity of care. And just to review, just in general, that how diagnoses impacts not only the capture of the diagnoses but reimbursement, because I know in healthcare we don't like to talk about the reimbursement, but this reimbursement is very important because this is what allows our facilities and our providers to be there to provide new programs, to provide new tests, to be there so that when we as patients present to their doors, we don't have to go to other facilities. And this example page just shows a general overview of how one diagnosis at one facility that has 354 admissions, which is average for an average-sized facility, can be almost $1 million a year difference in reimbursement just by capturing the appropriate severity of illness. And multiply this by multiple diagnoses that every facility and provider sees, and we can see that for a hospital of any type, this can mean millions, if not tens of millions of dollars per year, and providers, this can impact providers tens of thousands, if not hundreds of thousands of dollars per year, that makes them be there to be able to provide care for patients in the future. The bottom dollar, clear, appropriate, accurate documentation will impact hospital reimbursement and provider reimbursement in the ambulatory setting by accurately reflecting the patient's true severity of illness, risk of mortality, and justified consumption of resources. All healthcare providers can effectively improve physician documentation with the potential of capturing severity of illness, medical necessity, receiving appropriate revenues for, again, facilities, millions to tens of millions of dollars per year, providers, tens of thousands to hundreds of thousands of dollars a year, and this can continue as we transition in the ICD-10 when we are appropriately start documenting the specificity, and we can start doing that today. Thank you, and you have a great day.
Thank you, Dr. B. Continuing our webinar, I would like to present Attorney George Breen. Mr. Breen is a member of the firm Epstein, Becker, and Green, PC, in the healthcare, life sciences, and litigation practices. A litigator for over 25 years, Mr. Breen serves as the chair of the healthcare and life sciences practice at Epstein, Becker, and Green, PC, and is also a member of the firm's board of directors. Mr. Breen.
Thanks, Debbie, and good afternoon or good morning, everyone. It's a real pleasure to be able to speak to you today and to join Dr. Bibbins in this program. If we can turn to the first slide, I think the discussion of whether or not we're going to see ICD-10 in 2015 is really interesting. But if you look at some of the discussions that industry stakeholders have had, some statements that they have made, I think it gives you a flavor of where things might be headed. So if you look at a press release that CMS issued on July 31st, 2014, shortly after the delay to October 1st, 2015 was enacted, CMS states that the deadline allows providers, insurance companies, and others in the healthcare industry time to ramp up their operations to ensure their systems and business processes are ready to go on October 1st, 2015. In fact, the title of that press release, Deadline for ICD-10 allows healthcare industry ample time to prepare for change. CMS goes on and it says, as such, much of the industry has already invested resources toward the implementation of ICD-10. CMS has implemented a comprehensive testing approach, including end-to-end testing in 2015 to help ensure providers are ready. So CMS believes, or believed as of July of last year, that this extension, this further delay, would be sufficient to be able to move this forward. As many of you know, that is not an opinion that the provider community necessarily shares. And indeed, this past December, when there was the potential of a further delay in connection with the doc fix, many medical associations, we have on the screen now something from the Texas Medical Association, but it wasn't alone. State medical associations in New York and Missouri and Georgia all advocated for a further delay. You'll see on the screen a recommendation that the Texas Medical Association made to its membership, suggesting that a reach out be made to members of Congress asking that mandatory implementation be further delayed until October 2017, suggesting that congressional representatives ought to know that healthcare providers could not afford the cost and disruption of ICD and ICD-10 implementation to its businesses, particularly in light and as a result of the myriad of other bureaucratic burdens, according to the TMA, that providers were already facing. And if we turn to the next slide, the association also asked and provided to its members an email address to be able to obtain additional information. It has its own legislative action center, again, something similar to many other state associations, for providers to go and to get additional information and to get contact information for various members of Congress so that providers and those with whom they work would have a resource to contact to say you have to stop this, you have to continue this past 2015. If we turn to the next slide, you'll see that the Texas Medical Association also submitted to its members a proposed sample letter. What it suggested its members talk to and pass on to its representative, noting that making sure that the representatives were aware that there are about 68,000 diagnostic codes under the new ICD-10 coding system, 5 times more than in use under ICD-9. The reality that even looking at what CMS has projected, providers may not get paid for 3 to 6 months due to ICD-10 implementation, and that for some providers, the reality of not being paid for that length of time could literally force them to close their doors. The costs that they also reference reflect a significant expense, both from the government perspective as well as the individual provider perspective. And if we turn to the next slide, you'll see that this communication goes further and asks the representatives to recognize that this includes that there is a reality here in the provider community that it's also being forced to incur expense and resource to achieve meaningful use of electronic health records, to meet the quality measures under Medicare's physician quality reporting system, as well as other programs, and in addition to the implementation and the provisions subsumed within the Affordable Care Act. And they encourage that there be a reach out to individual representatives. However, I will say, and if we turn to the next slide, that there are also opponents to a delay. There are those that believe that a delay really does not make sense at this point. We've heard from CMS and what CMS believes to be the appropriate course, which I think is implemented in 2015. But there are other industry players. The College of Healthcare Information Management Executives has said that there have been considerable hours, resources, and money its members and their organizations have spent preparing for the transition, and that in fact the delay was harmful, that it discredits the significant work its members had spent training staff, conducting testing, and converting systems. The American Health Information Management Association similarly recognizes that at the end of the day, a transition is inevitable, but it's also time sensitive, and that there are in fact risks to the public health by a further delay, that it recognizes that there are technical issues involved here, but that in its view, it doesn't see that there really is any value or any reason to further continue or to further delay the implementation of ICD-10. If we go to the next slide, similar to the various state medical associations, the American Medical Association has said it's committed to relieving physicians of the crushing administrative burdens and practice disruptions associated with the ICD-10. There was no success in December in securing a further delay. Don't know that there will be any different result, but it's evident that players in the industry have differing viewpoints as to whether or not it would be appropriate to have a further delay of ICD-10. If we turn to the next slide, on December 10th, 2014, House Energy and Commerce Committee Chairman Fred Upton and House Rules Committee Chairman Pete Sessions issued a joint statement in response, I think at least in part, to the reaction that they had received from the various industry players, and they promised that they will work with CMS to ensure that the deadline can successfully be met by stakeholders. I think the reality here is, if you look at the current composition of this Congress and you look at the question, do we think ICD-10 implementation comes in 2015, you need to consider what this Congress will be principally focused on as it relates to health care. And frankly, no one knows whether there will be a further delay. I think if you consider the positions and you see and you look at what this Congress is particularly interested in, I don't think a further delay is something that's going to be top of mind in Congress this year. Congress principally this year is going to be looking at the Affordable Care Act. There will be, I would presume, a pro forma attempt to repeal the Affordable Care Act. I think most folks will tell you that that attempt is going to be unsuccessful. There may be an effort to get it to the President's desk, but I don't think it's successful, and I don't think that the industry believes that it would be. I think the next turn is going to be to repeal or to amend various provisions of the Affordable Care Act. You've already seen recently, as the new Congress has come on board this month, an effort to address the medical device tax provision of the Affordable Care Act. You will see efforts to address the employer mandate and efforts to be able to repeal that or to amend that. You have issues relative to the exchanges and whether subsidies that are available under the Affordable Care Act are available both under state exchanges as well as the federal exchange. And there is litigation in the courts presently pending to address that issue. So I think if you consider the totality of the circumstances, the healthcare-related focus that Congress will have this year is likely not one to be focused on the delay, further delay of ICD-10. So I would not be surprised if, as of October 1st, 2015, you saw ICD-10 being fully implemented. But apart from the challenges that Dr. Bibbins has spoken so well about with regard to implementing ICD-10 and the costs and the issues surrounding that, if we turn to the next slide, I think the reality is that ICD-10 brings with it some increased risk. And that is largely because of the level of specificity required by ICD-10 and the need to capture complete and accurate clinical documentation of a patient's condition. The reality is that the transition to ICD-10 will bring with it a greater spotlight on providers and what it is that they are documenting, how it is that they are billing for the services that they are providing. And it's not just Medicare. Commercial payers that are working with Medicare and risk adjustment models are going to be much more attuned to the notion of, is there support for the documentation of the level of the severity of the illness or disease of the patient that the provider is providing care for. I think as you look at that and think about what ICD-10 also brings, it is also going to bring, and Dr. Bibbins alluded to this, increased and overly aggressive payer audits looking at medical necessity. My practice is focused on representing healthcare providers in government investigations and litigation across the country. The reality is that the issues of medical necessity and quality of care are issues that are increasingly ones that the government is very interested in. The notion of having ICD-10 come on board actually assists the government in its effort to continue to address medical necessity issues, because it will be looking for this increased level of specificity and will be looking for the documentation to support the billing which reflects a particular disease state a particular treatment, and it will use those decisions that are made relative to the particular ICD-10 code as evidence to suggest that there may be something improvident going on, even in those situations where the reality is so much of this may simply be the result of providers trying to learn how to operate in this system in the most appropriate way. And I think it also results separate and apart from increased payer audits and more aggressive payer audits and an effort by the federal government and those that bring cases on behalf of the federal government to pursue providers under the Federal False Claims Act. If we turn to the next slide, the issues of medical necessity and quality of care aren't new to this Department of Justice. If you go back to November of 2010, the then Assistant Attorney General for the Civil Division, Tony West, when he was announcing the fraud recoveries that the department had achieved over the past 12 months, talked about the types of cases that the government was interested in pursuing. And they're talking about cases that go to the, and you'll see it on your screen, that go to the heart of providing quality care to our most vulnerable citizens. So that if anyone had any doubt but that, looking at quality of care also gives the government another opportunity to enforce. You need only look at what the Department of Justice says in its public statements to understand that it's looking at quality of care from an enforcement perspective as well. If we turn to the next slide, the issues of medically necessary care and coverage are ones that are in the statute. Within Medicare, as we all know, there are coverage categories. And Medicare coverage is limited to items and services that are reasonable and necessary for the diagnosis and treatment of illness or injury. If we can turn to the next slide, Medicare requires that healthcare practitioners and providers assure that the services that they are providing and that they've ordered are provided economically, and then only to the extent medically necessary. The notion of the transition to ICD-10 will be, and looking at the codes selected and used, are going to be ones where this issue of medical necessity is going to be directly spotlighted by the federal government. If we turn to the next slide, the reality is that the Office of the Inspector General has for some time, going back to 2000 and its compliance guidance for individuals and small group physician practices, physicians need to understand Medicare is only going to pay for services that meet the Medicare definition of reasonable and necessary. And physicians can only bill for services that meet that reasonable and necessary standard. If we turn to the next slide, is that the government's best weapon, it's the best tool in its toolbox as it relates to enforcing enforcement efforts against providers, is the False Claims Act. November 20th, 2014, the Department of Justice issued its annual report on the fraud recoveries that it had secured over the past 12 months. Last year alone, the Department of Justice recovered $5.69 billion in settlements and judgments from civil cases involving fraud and false claims against the government. It is the first time in history that the department exceeded $5 billion in cases under the False Claims Act. And going back to 2009, the total recovered is $22.75 billion. Most of these recoveries are the result of relators' actions. Relators are private citizens who, under the Federal False Claims Act, are allowed to bring cases in the name of the federal government. They bring these cases. These cases are investigated by the Department of Justice. The Department of Justice can elect to intervene and litigate the case itself, or it may allow the relator to litigate the case on behalf of the federal government, and the recoveries are significant. If the government prevails in a False Claims Act case, the relator can receive up to 30% of the recovery. And why that's so important, if you look at the numbers of cases that are actually filed, last year, fiscal year 2014, the number of False Claims Act cases filed exceeded 700 for the second year in a row. and that recoveries in cases brought under the False Claims Act in 2014 totaled nearly $3 billion, with whistleblowers receiving $435 million. If you look just at healthcare fraud recoveries, what the government obtained under the False Claims Act in civil settlements and judgments, $2.3 billion of the $5.69 billion was related to healthcare fraud. That makes it 5 years in a row that the Department of Justice has recovered more than $2 billion in cases involving false claims. Looking just for the period January 2009 to 2014, for healthcare fraud cases, the recovery is $14.5 billion. Of that recovery, again, is the huge amount that's going to whistleblowers under the provisions under the False Claims Act. So why does it matter? It matters because the False Claims Act is such a significant effort. Under the False Claims Act, the False Claims Act penalizes the submission of a false or fraudulent claim or the submission of a false record or statement to support a claim to the federal government. Unlike other cases that are brought under fraud, the government does not need to show a specific intent to defraud. All the government needs to show in order to be successful under the False Claims Act is that the provider knew or should have known that what was being submitted was false or fraudulent, that he or she or it acted in deliberate ignorance of the truth or falsity, or acted in reckless disregard. And that whether you submit the claim or whether you cause the claim to be submitted, you can still be held liable under the Federal False Claims Act. If we turn the page, there are a variety of actions that are impacted here that are prohibited under the False Claims Act. And the reality is that the government increasingly, and if you look at cases that have been publicized, particularly as we go through 2014, the issues of quality and medical necessity really permeate through many of these cases. Why does this matter so much? And if we turn to the next slide, please. Because the consequences of a False Claims Act case and losing one are very significant. In a False Claims Act case, the government is not seeking only the dollar amount of the claim that was submitted that was allegedly false or fraudulent. They're entitled to treble damages, 3 times that amount. There are penalties that are associated with the False Claims Act, and penalties range from $5,500 to $11,000 per claim. What that means, ladies and gentlemen, for all practical purposes, is that penalties alone can result in a business being forced to close its doors. If the government is successful in a False Claims Act case, the next step is that the Office of the Inspector General has the ability to suspend and to exclude that business and individuals associated with that business from participation in federal health care programs. That means they're taking that business, they're taking those players out of the game, some for various periods of time. As many of you know, if you're unable to do business with the federal government, your private contracts often require the ability to do business with the federal government as a condition to be able to be in business with them. So it is really the death knell for healthcare providers. So the idea that ICD-10 is coming and the complexities that it brings with it really becomes, from my perspective, of heightened importance because of the exposure that it presents. If we turn to the next page, and recent amendments to the False Claims Act, quite frankly, have made it easier to file a False Claims Act case. In 2009, the False Claims Act was amended by the Fraud Enforcement Recovery Act of 2009. It was also amended in 2010 by the Affordable Care Act, and there are particular provisions that are significant as we think about ICD-10 and its implementation. For example, it's easy to file a False Claims Act case now because before 2009, if a case was filed and the allegations in the case were based on information that had been disclosed by another source, in congressional testimony, for example. The law said that a case that was based on those allegations couldn't proceed because the law required that the person bringing the case, the relator, had to be the original source of the information. He, she, or it had to have provided this information for the first time to the federal government, and if they weren't the original source, then the court had the ability to dismiss the case. Well, now, given the amendment, now the court can dismiss the case unless the government opposes it. So the government now has the right to come in and to say, yes, it may not have been the original source, but it provided additional information, or otherwise it should be permitted to remain as a party plaintiff, and allows the defendant to be allows the Department of Justice to be the gatekeeper. Now, again, I litigate these cases fairly frequently. I will say that the Department of Justice has been judicious in terms of when it elects to stand in the way of a dismissal under these circumstances. But I'll also tell you that it has exercised this new authority, and this makes it easier and, in fact, encourages relators to pursue False Claims Act cases. If we turn to the next slide, and actually the next slide after that for the purposes of some clarity, one of the other significant changes to the False Claims Act came in the form of a reverse false claim, meaning that let's not talk about actually submitting a false claim, but if you have submitted a claim and you've been paid, and you're in possession of money that you knew or you should have known you're not entitled to, simply keeping the money itself also constitutes a false claim. So even in the innocent situation, you submit bills, you get paid, for whatever reason, the government elects to pay you more than you are entitled to. If you do not report and return that money, and if we can turn to the next slide, within 60 days, that is in and of itself an overpayment which is subjected to False Claims Act liability. Simply keeping the money, therefore, and not returning it makes you subject to a potential False Claims Act violation. Now, this is particularly significant when we think about ICD-10 and not only looking at what we're billing and how we're billing it, but what are we doing to evaluate our processes? And are we looking at these claims after the fact also to understand whether there are any issues that we ought to be forthrightly addressing with the government and in some cases, returning funds to the government, because that's what the government expects. And it expects you to do that within 60 days of discovery. That doesn't mean 60 days of the date you get paid. It's 60 days of the date that you realize I've now been paid more than I was entitled to, or I don't have documentation in my file to support the claims that I've submitted. The reality is that the government is encouraging self-audit, is encouraging self-reporting. I will tell you that there has been a proposed rule that was offered by the government almost 2 years ago with regard to the 60-day overpayment rule. It has yet to be finalized. And what providers ought to know is that as part of that proposed rule, the government proposed a 10-year look-back. In most instances under the False Claims Act, it's a 6-year statute of limitations. The government can only go back 6 years. Under this proposed rule, with regard to overpayments, it's a potential 10-year look-back, which means that if you've got documentation management systems and retention policies, you need to be watching for this proposed rule because it's expecting there to be a 10-year look-back, and we'll see whether that final rule comes into effect. I would suggest to you that while some of the issues in the proposed rule may not come into effect, I would not be at all surprised to see that 10-year rule remain. I do think, as a practical matter, that ICD-10 implementation increases the potential for physician liability, and the likelihood that actions based on improper claim submission will be pursued under the False Claims Act. The specificity required by ICD-10, the detail that's expected to be used to code, is going to make it easier to meet the standard of knowing, deliberate ignorance, reckless disregard. ICD-10 requires more detail pertaining to the diagnosis within a single code. Things like severity, particular body parts, external causes of injury. Even socioeconomic and environmental factors are ones that are captured here. And if you look back in 2013 to the guidelines that were published by CMS to accompany the ICD-10, they direct the provider to code with the highest possible level of specificity, which means that the government's going to take that and look at that and really try to analyze whether these codes were utilized appropriately, whether they do support the illness, disease treatment that was provided, and if they do not, you can expect them to look specifically at these codes and say, this code is not supported, this was a false claim. So for those of you that may be struggling within your organizations to deal with the implementation and the costs and the issues arising around ICD-10, please recognize and tell your colleagues that you're not only dealing with the changes with billing, it is so significant that and because the risks are increasing under the False Claims Act, under the actions of the various CMS contractors, that you need to make sure that you're prepared, you need to make sure that you're doing it the right way. And I would suggest to you that I would expect October 1st, 2015 is the date you need to be concerned about. Thanks so much.
Thank you, Mr. Breen. We appreciate that. During the presentation, there were several questions submitted. We will take a moment and address them. Questions that we are unable to answer at this time due to the time constraints will be sent to you by way of email. Mr. Breen, this question is addressed to you. Is it better to skip ICD-10 entirely and move right into ICD-11?
You know, it's interesting because I think the last report that I saw suggested that ICD-11 would be ready to go by 2017. And it raises the question as to whether, given that, and those proponents who suggest we ought to move and wait until 2017, whether that's the right way to go. At this juncture, given the costs and the resources that have been expended for people to get prepared for and to live with ICD-10, I think it probably would not be better to wait until ICD-11 and to implement that. I think it would actually result in delay, in further delay. I think it's going to result in increased costs. I think it's going to be more problematic for the provider community, frankly, to be in a position where they're going to have to then go to ICD-11 and deal with that before they ever really fully develop or process the issues relative to ICD-10. So I'd have to say that, in my opinion, it probably wouldn't make sense to do that.
Thank you, Mr. Breen. Dr. Bibbins, this question is addressed to you. Will CMS and private party payers be able to process more insurance claims the first time they are submitted without requiring additional documentation due to more specific codes in ICD-10?
This is a multiple level complex question. Number one, let's start with CMS and private payers are reimbursed different ways. Private payers look at the claim submitted and determine whether they appear appropriate. They may then request supporting documentation, this is today, In ICD-10, I do not anticipate that will change. They will request the additional documentation before they pay the claim for the care provided. CMS, because of the massive numbers of claims it has received historically, and that is over 9,000 claims per minute. And when you multiply this, there is very little chance for them to review claims before they're paid, if they are to be paid in a timely manner. Therefore, CMS pays claims and then comes back and reviews to see if they are appropriate. And that's where documentation across the board has been historically required, and will probably be even more required and audited to make sure that the specificity of ICD-10 has the words in the medical record or the documentation of the clinical care to support the specific codes that are selected. So we anticipate that private insurers will probably still do it the same way. There will always be audits. That's checks and balances that are done across the board. And facilities are encouraged to do these checks and balances by internal auditors, by the utilization review committees, and these components in the hospital, so that this will allow facilities as well as physicians' offices with internal reviews to catch any errors, or if more documentation to support the selected codes is needed, then everything can be appropriately put together and placed within the medical record prior to it being submitted to Medicare and to private insurers. With this occurring, then when Medicare does its routine and a lot of times random audits, again, there are targeted audits for specific diagnoses also that appear to have a greater chance of being incorrectly coded and billed, and therefore they go back to the basic of documentation or lack of documentation to support the codes and the billing. When everyone goes back to look for this documentation, if it is there appropriately, then CMS will not be recovering resources, or it may impact the degree or percentage of recovery, depends on specificity and the documentation, and private payers will go and pay the claims then. So for ICD-10, we would hope that the greater specificity in coding would decrease to a degree some of the audits. But when the audits are done, there would need to be the specificity of documentation there to warrant not as many audits being done. So basically, we have to prove that we're doing the documentation that, unfortunately, we have not in healthcare proven at this point that we can do, since, again, we've been in ICD-9 for over 30 years, and they are getting, they're capturing so much in recoupments because of the question of appropriate documentation specificity, which then would lead to question mark appropriate or inappropriate coding and billing.
Thank you, Dr. B. We do have another question for Mr. Breen, and I think this will be the last one that we will have time to do. The question, Mr. Breen, is, what can I do to have my individual voice heard about my opinion about starting ICD-10?
So I think that there are a couple of things to think about as it relates to that. Certainly, individuals have the right to contact their various congressional representatives to express their opinions relative to ICD-10 and the right time for it to be implemented. The reality is that volume matters, numbers matter, And so that to the extent that can be part of or coordinated with associations, medical associations, and others that you may be affiliated with, numbers matter to representatives on the Hill. Calling, writing, faxing, emailing, the associations often have the ability to meet with individual members of Congress at the staff level, and those staff meetings are ones where you have the opportunity to express opinions in a fashion that may lead to some further action that will give, where the representative may give further credence and weight and consideration of the issues here. So I think certainly there can be an individual reach out, and you can do that by phone to your representative, by fax, by email, even by regular old snail mail. But it's working with associations and having the association speak as a voice backed by numbers that sends the strongest message, because that's what the representatives will be looking at in terms of the numbers and how it is and how many people it is that this really impacts. So it's really neat. I think it really needs to be a coordinated effort. Certainly your individual voice is a part, and a very important part of that, as I think is reflected if you look at the Texas Medical Association letter, the similar communications that other states have passed to their members, trying to get as many voices as possible in front of Congress to say, this just is not the right time for a myriad of reasons.
Thank you, Mr. Breen. Dr. Bibbins and Dr. Breen, I want to thank you both for this excellent presentation today and what we can expect in the coming months with ICD-10. I want to thank the audience for attending our webinar. Be sure to frequently visit our websites and sponsor for updates on America's Healthcare Network. Thank you very much.